One of the most important features of the vascular system is elasticity, which allows arteries to expand and contract, propelling blood through the body at a face-melting 3 to 4 miles per hour. Okay, I'll admit, a bit underwhelming. But this rubberiness of the blood vessels is crucial for normal function. Sometimes, however, the wall gets weak. The artery expands and it's aneurysm time. In this scene, we're going to be looking at the largest artery of them all, the aorta, the most common site for aneurysm formation. And for the grand finale, we're going to turn up the pressure and cause the whole thing to rupture. So grab a pair of aviators, turn the Kenny Loggins up to 11, and from now on, address me by my call sign. Because we're headed to Naval Flying School. Ugh, God. Memories of Caddyshack 2. So underwhelming. That's better. You may recall that we've seen aneurysms already, where we covered the complications that follow myocardial infarction. A few weeks to months after a transmural infarct, the weakened ventricular wall may start to bulge outwards, resulting in a ventricular aneurysm. This time, it's all about the aorta. But as you'll soon see, the pathogenesis of aortic aneurysm is pretty similar. Some kind of initial insult weakens the arterial wall. Eventually, it loses its elasticity and starts to bulge under the pressure. An aneurysm is defined as a focal vessel expansion over 1.5 times larger than the normal vessel diameter. It can be saccular and butt off of one side of the artery, or it can be fusiform and involve the entire circumference of an arterial segment. The saccular variety classically pop up in the cranial vasculature, while the fusiform aneurysms featured in this sketch are most commonly seen in the aortic arch, abdominal aorta, and iliac arteries. Another distinction to keep in mind is true versus false aneurysm. True aneurysms contain all layers of the vascular wall, the intima, media, and adventitia, also called the externa, as depicted by the markings on the landing strip: purple for intima, red for the smooth muscle of the media, and tan for adventitia. False aneurysms, or pseudoaneurysms, on the other hand, don't include all the layers. One example of this is seen in the setting of vascular trauma, when rupture of the intima causes the formation of a periarterial hematoma encased in adventitia. We're going to stick with true aneurysms, however, and the most common place to find one of these is in the abdominal aorta. Also, you see how we've placed the bulge underneath those kidney-esque pulleys? Abdominal aortic aneurysms, or AAAs as they're called, are usually found in the infrarenal aorta, below the renal arteries, in other words, which is a good thing, because when it does involve the renal arteries, which occurs in about 5% of cases, the overall prognosis is worse. This can lead to kidney injury, and treatment is much more difficult. Now, the whole point here is that we need an initial injury, something that causes a localized weakness in the vessel wall so that it starts expanding. In the case of AAA, the pathologic mechanisms of aneurysm development and progression aren't fully understood, and are probably multifactorial. Nevertheless, we do know what risk factors contribute to aneurysm formation. The big one to remember is atherosclerosis. It turns out that many patients diagnosed with AAA will also have coronary artery disease or peripheral artery disease at presentation. Not only that, atheromatous plaques are commonly found right inside the aneurysm. Here's where it gets a little hazy. It's logical to think that the plaque itself is responsible for the initial aortic injury that leads to aneurysm formation. You've got all the ingredients. There's local inflammation. Throw in some metalloproteinase and elastase activity. Maybe even some cell necrosis. You know, all that stuff we covered in our atherosclerosis treasure hunt sketch. And bam! A weakened and dilated aorta. Studies increasingly show, however, that atherosclerosis may occur in parallel with aortic aneurysms, rather than directly cause it. In other words, these two processes share many risk factors, and thus can occur together. The most prominent risk factors include age, cigarette smoking, and male sex, all of which are embodied by Commander Wetcalf. Just look at all those ribbons and medals and semen regalia all over a shirt. I could have used better phrasing. What I'm getting at here is, this guy's been around for a while. which is pretty fitting because the incidence and prevalence of abdominal aortic aneurysm is pretty insignificant in populations under the age of 60. It's pretty rare in women as well. The prototypical patient is a 65 to 80-year-old Caucasian man. In fact, 5 to 10% of patients in this demographic will have a AAA. Not only is the amount of smoking correlated with the risk of developing AAA, it's also associated with larger and more dangerous aneurysms. So talk to your patient about smoking cessation. Quitting will decrease the odds of developing a AAA, with the greatest benefit among those who have quit for more than 10 years. Unfortunately, the odds never return to baseline, suggesting that some degree of vessel damage inflicted by smoking is permanent. All right, before we get to histology, let's move a bit further up the aorta and talk about thoracic aneurysms. The ascending aorta, which encompasses the proximal aortic arch, is the second most common place to find aortic aneurysms. Just like AAAs, thoracic aortic aneurysms develop because of some kind of initial injury to the vessel wall, causing loss of elasticity and focal expansion. And I hate to say it, but the pathologic mechanisms of thoracic aneurysm development and progression aren't entirely understood, and again, are probably multifactorial. Of the patients who present with a thoracic aneurysm, about a quarter will also have an abdominal aneurysm. So, as you might guess, their risk factors are pretty similar. And yet again, it's all about atherosclerosis. Unlike the abdominal aorta, however, where you'll commonly find atheromatous plaques right inside the diseased aorta, the ascending thoracic aorta rarely shows signs of atherosclerosis. So remember, we're not looking for physical plaque deposition here. What we're concerned about are the risk factors associated with atherosclerosis, many of which overlap with the risk factors for thoracic aneurysm. An important one seems to be hypertension, which is present in over 60% of patients with thoracic aortic aneurysm. Higher pressures also increase the risk of expansion and rupture, so aggressive management of hypertension is key. Two more important risk factors for thoracic aneurysm are shared with abdominal aneurysms, and that's smoking and age, both of which are thought to contribute to the ongoing damage and weakening of the aortic wall. This is why we've placed Old Commander wet calf next to both the abdominal pipe and the thoracic pipe. Genes play an important role here as well. One of the most common genetically inherited conditions associated with aneurysm formation is Marfan syndrome, embodied by our recurring Marfan. Marfan syndrome is a connective tissue disorder with an autosomal dominant mode of inheritance. In its most common form, this disorder is caused by a mutation in the fibrillin gene, an important component of elastic tissue. Breakdown of the elastic components of the aortic wall can result in aneurysm formation, especially in the thoracic region, right around the root of the aorta. In addition, patients classically have long, thin extremities, as well as impaired vision due to dislocation of the lens. While we're at it, let's throw bicuspid aortic valve into the mix as well, symbolized by this bicuspid windsock. Bicuspid aortic valve is a heritable disorder that results in a 2-leaflet rather than 3-leaflet aortic valve. In many cases, the aortic root and ascending aorta are weakened and begin to dilate. And about 25% of patients will require repair at some point in their lives. Turner syndrome, because of its association with bicuspid aortic valve, coarctation, and aortic dilation, is another common finding in young patients diagnosed with thoracic aortic aneurysm. Turner syndrome, as usual, is symbolized by the turning blades of a windmill. Plus, the X shape should remind you of the XO Turner genotype. Check out our genetic disorders unit for way more info on this disorder. Obviously, genes are important here. And to top it all off, let's talk about family history, as evidenced by the long line of Navy commanders in his family tree. It's thought that many affected patients have a genetic predisposition for aneurysm formation. Patients who have a family history of AAA, for example, are 2 to 5 times more likely to develop an aortic aneurysm themselves. And for thoracic aneurysms, it turns out that about 20% of patients have some kind of family history of aneurysmal disease. And that's not even counting the cases due to known genetic conditions such as Marfan and Turner syndrome. So let's put this all together. Start with a genetic predisposition, add on some vessel-damaging risk factors such as hypertension and smoking, Let it age for a bit. Finish it off with just the normal wear and tear that these large arteries feel on a daily basis, and you've set yourself up for an aneurysm. If you zoom in on that weakened aortic wall, you'll see some pretty extensive structural remodeling. The characteristic histological changes are dubbed cystic medial degeneration, just a fancy term for the smooth muscle-rich media turning to mush. First, look for a transmural infiltrate of inflammatory cells, as depicted by those little blue nuts and bolts, just like the little blue nuclei of invading cells. In the wall of an abdominal aneurysm, you usually find lots of T cells, B cells, and macrophages, which is indicative of a Th2 immune response. In thoracic aneurysms, look for lots of T cells, more of a Th1 kind of response, which involves an invasion of natural killer cells and cytotoxic T cells. Next, take a look for degradation of the elastic lamina and surrounding extracellular matrix. That snapped elastic wire, meant to catch the jets as they land, evokes an image of the fragmented, randomly arranged elastic fibers seen on histology. Matrix metalloproteinases probably play an important role in extracellular matrix degradation, represented here by those sharp metallic tools scattered in the area. These enzymes are secreted by the inflammatory cells, smooth muscle cells, and endothelial cells. Cystic medial degeneration is also characterized by a reduction in the number of smooth muscle cells due to apoptosis. Necrosis occurs as well, causing the accumulation of a basophilic mucopolysaccharide substance. This separates the normal tissues, further weakening the vessel wall. It's important to know that even though it's called cystic